All right, I'd like to welcome Dr. Angus Lane, the next speaker, who's currently our registrar at the Prince Charles Hospital. Angus is a dual trainee, ID and Gen Med, Masters of Public Health and Tropical Medicine from JCU. And interestingly, at the commencement interview, found out that your interest is in the provision of healthcare for marginalized people. And more recently, your visit to Milan, where you observed the use of whole genome sequencing to map the rates of antimicrobial resistance. I'm guessing of the pathogen, not the scientists.
Thank you, Alex, for that warm introduction. And thank you for the speaker so far. Ready to go. So today I'm going to present a case of disseminated aspergillosis in an immunocompromised patient, one of our heart transplant patients. And there's a few key things that I want to take away from this talk, and I think it should build really nicely on what we've discussed so far. So the case is that of a 69-year-old lady who was admitted in November of 2022 after crashing onto an LVAD device, basically in the context of ischemic cardiomyopathy. At the time of LVAD insertion, she was determined to be a suitable candidate for transplant and went on to receive a heart shortly thereafter. Her post-transplant course was complicated, as you can see, by a non-oliguric AKI, a return to theatre, bronchopleural fistula, and requiring ICC placement, all of which we've learned from our previous talks increase the risk of an invasive fungal infection. It's important to note at this point in the talk, on her serial echocardiography, there was no evidence of infective endocarditis, and she was discharged 6 to 8 weeks after her initial transplantation in a fit and well condition, notably with neutrophils of 9.33, but at the time attributed to the steroid dose which she was on. At the time of discharge, you can see her immunosuppression and prophylaxis was thus. And shortly thereafter, in a matter of 4 weeks, she re-presented with a persistent cough and back pain and increased white cell count. At that time, she went on to tell the team that the cough had really been there since she left hospital the first time around, but her dyspnea had progressed, her exercise tolerance had reduced, such that she was now having 3-pillow orthopnea despite a perfectly functioning transplanted heart. Notably, her prednisolone dose at that time was 20 milligrams a day. She had a raised white cell count and CRP, and in that context went on to have a septic screen. I've put a little spoiler down here. So shortly into her case, we had the return of an Aspergillus fumigatus sputum, but we didn't, of course, have the luxury of that culture at that time. So the heart transplant team engaged us as the ID team to come and provide some advice, and we proceeded with a CT chest. Similar to Andrew's talk, the comment from the radiology consultant at this time was that a lymphoproliferative disorder should be considered despite such a short interval between transplantation. So a lymphoproliferative disorder was raised in the diagnosis. We were, however, suspicious for other, of course, etiologies. So progress of the case throughout her admission, the lung transplant team were consulted and agreed with our initial impression that there was concern for a fungal infection. They suggested the addition of a cryptococcal antigen and a bronchoscopy. Of note, at the initial ID consult by the team, I really want to point out that the patient, when questioned, didn't raise the concern of any lumps or bumps cutaneously. However, when we went on to examine her, there were considerable leg palpable nodules, as you can see demonstrated in the imaging there. So we worked in a multidisciplinary fashion, which has been highlighted in the previous talks to be key to good outcomes in these patients. And our lung transplant team very kindly came on board and offered this lady a bronchoscopy. At the time of her bronchoscopy, the findings were largely unremarkable. There was a little bit of mucus down in one of the bronchial trees, but otherwise there was no significant inflammation, erythema, or obvious infection. We now start to have results trickling back into the case, and you can see that her galactomannan was mildly elevated, and there was fungus on her lavage samples. We proceeded with skin biopsying of one of those raised nodules, and you can see here the report is in keeping with a disseminated invasive aspergillosis diagnosis. So in terms of cutaneous manifestations of invasive aspergillosis, I wanted to touch on here for a moment. Prior to 2015, there was a paucity of data in this specific area of aspergillosis. And at that time, the French mycosis study group went on to publish a very large case series from their registry data, where they looked at all of their proven and probable invasive aspergillosis cutaneous manifestations. And at that time, they basically came up with the recommendation that any erythematous or papular or nodular lesion in such patients should be considered for investigation for invasive sampling. The American Infectious Disease Society practice guidelines, notably as well, recommend treatment for voriconazole with cutaneous invasive aspergillosis. Unfortunately, our patient, despite being initiated on voriconazole therapy, went on to develop a painful left eye. She had very limited extraocular movements at the time of that presentation, and significant loss of vision. As you can see there, she was unable to determine any numbers on pinhole assessment, only movement. So the ophthalmology team was then engaged, and she was commenced on intravitreal injections. Her ocular symptoms progressed, and in that context, she also had an MRI brain, the image of which you can see before you, and we demonstrated quite considerable CNS involvement. Notably here as well, she's had serial echocardiographic imaging, which didn't demonstrate any evidence of infective endocarditis. Our ophthalmology colleagues were, again, quite involved throughout the case, and ultimately were concerned that this was Aspergillus endocarditis, and she went on to develop a necrotic glaucoma and choriovitriol detachment with significant pain associated with that. So quite a stressful and challenging experience for the patient herself, ultimately leading to loss of vision in that eye, unfortunately. At this point in time, there was consideration as to whether or not we should go for aggressive surgical debridement. And upon reading the literature for management of ocular aspergillosis and invasive fungal infections, there seems to be an emerging pattern where previously radical surgical debridement was the mainstay of therapy in addition to systemic antifungals. Now have a much more nuanced approach, is having favorable outcomes in patients. Obviously, these are very small sample sizes, unfortunately, and so it's difficult to infer with any great certainty, but certainly the early signals is that we can be much more apprehensive about taking the knife to the patient, which I think when we're talking about quite disfiguring surgery is a really important consideration. In terms of intravitreal treatment, amphotericin B is very commonly in use, in addition to voriconazole. Of note, there is evidence in the literature that amphotericin B comes with increased risk of toxicity, particularly to the retina. So if there's a possibility of salvaging sight, we should really look to avoid that, I think, and favor voriconazole in that context. But again, we have really, really limited literature in these cases. And you can see there quite remarkable difference between the orbits on her MRI scan at this point in time. Following on from what I was saying about intravitreal treatment, the practice guidelines for diagnosis and management of aspergillosis per the Infectious Disease Society of America recommends that endophthalmitis be treated with oral or intravenous voriconazole plus intravitreal voriconazole. In terms of our drug selection, Cass really nicely spoke about the use of antifungal therapy earlier today. And there are a large number of considerations, particularly in our transplant patients with regards to drug-drug interactions, be that immunosuppression or other medications. And then further to that, are we going to actually target the site that we want to? And so in this lady, posaconazole perhaps had a more favorable interaction profile with her immunosuppression, but we weren't going to be able to adequately target the dissemination of the CNS and ocular involvement. In terms of her ongoing outcome, she was quite recently seen in clinic. You can see the CRP trend before you, and I'm really pleased to report that she's had no new headaches or worsening of vision in her left eye. She's developed no new cutaneous nodules and continues on voriconazole and is tolerating that quite well. She has made the decision to move back to Adelaide, where she's well supported by family and friends. And so her care is slowly being transitioned across to a team down there. But certainly the decision of whether or not she'll go on to have a total enucleation of that involved eye needs to be revisited. In terms of CNS infection, ocular infection, bone infection, voriconazole does seem to be favoured in the literature, and certainly the Society of America recommends that really as the backbone, a lot of their invasive aspergillus therapy. But of course, it's much more nuanced than that, and each patient really needs to have a personalised approach to their therapy and management. A multidisciplinary approach, I think, is really, really important in these cases. Her care was unfolding across 2 hospital sites, 20 kilometres apart, between the ophthalmological team and the heart transplant team and infectious disease team. And so the thing that I really want people to take away from this talk is that fungal infection rates are high in transplant patients in the first 3 months. Pertaining to orbital aspergillosis, we could perhaps be more nuanced with our surgical approach and go for less aggressive debridement, given the promise of systemic antifungal therapy. Any cutaneous manifestation should really prompt diagnostic sampling to exclude manifestation of infection there. And then choice of therapy obviously is very complex. Lastly, we really need to maintain a high index of suspicion with these cases. And inferring back to the comment I made earlier, initially when we asked this patient, did she have any nodules or skin changes? She said no, but then a thorough examination found those. And so particularly for junior trainees and young clinicians, that's something that I want them to take away from this, is to be very, very thorough. In the setting of immunosuppression, the symptoms may not be quite as typical as usual.